We are here today to discuss the path forward to the health IT modernization for Indian country. We all know that critical important to ensure that health facilities have access to modern health IT systems. We also know that adequate or up-to-date health IT systems we need have been long and a rocky road. This summit will provide us an opportunity to have a tribal-led and a tribal-focused forum in which to engage with this important topic and come together to develop a roadmap to move forward. Before I introduce our host for today's summits, I would like to recognize the sponsors of this event. Leidos, their generous donations made this event possible. We are excited to be joined by Carolyn, who will be hosting the rest of today's conference. Carolyn is the president of Crown Consulting and Management, a health consultant business specializes in tribal health system development and transition management since 2001. She has 40 years of experience working in the tribal health space, including senior management within 2 regional tribal health organizations in Alaska. We're also excited that she could lend her knowledge and expertise as we navigate in this very complex topic. Thank you, Carolyn, for joining us today. I'll yield the floor to you. Have a great day. Carolyn, are you there?
I'm there. I'm here. Can you see me?
We can see your
okay, here we go. All right, well, thank you, Chief Bill, for providing such a warm welcoming and for setting the tone, which for a historic effort, I think, to change the trajectory of how we deliver healthcare in a modernized environment. Thank you for your introduction. I have, as you mentioned, over 40 years of experience working within the tribal health space. And my passion has been working within the health IT modernization effort, being the former chair of the Information Systems Advisory Committee, as well as a current representative for Alaska, and then also work on the national budget formulation and wearing various hats over the past few years. So this is very exciting for me, and I'm hoping that everyone will be engaged and we'll come up with some excellent recommendations. We also want to recognize you, Chief Bill, and let you know how much we appreciate your dedicated service, not only to our country, but to Indian country as a whole. We want to thank you for all that you do and also congratulate you on your recent appointment to the Veterans Affairs Tribal Advisory Committee on Tribal and Indian Affairs. It's very exciting to have you representing all of us across the country in these important venues. So good morning and afternoon to those of you on the East Coast. Again, my name is Carolyn Crowder, and I'm excited to share this space with you on this exciting topic today. So today's summit will be an opportunity to look at issues surrounding health IT modernization from a variety of perspectives. We do have Indian Health Services joining us at the beginning of the session, but primarily this session is designed for tribes to have the space to get together and to talk about issues that are important to them and how we want to strategically proceed in this with this new opportunity before us. First, we will hear from Leidos about important considerations for health IT from the industry perspective. Again, thank you for your generous sponsorship of this summit. And then we'll take a brief look at the history of health IT modernization in Indian country from a self-governance and OIT perspective. During today's summit, we will explore what it means for health IT modernization process to be tribally led. And we thank Alaska for volunteering to share their experience to help guide our path in the future. We'll also be joined by the Department of Veterans Office of Affairs Office of Electronic Health Record Modernization to hear about their experience modernizing their electronic health record system. As many of you know, we have had a strong partnership with the VA in the past and continue to have with the RPMS system. Later then, we'll engage in roundtable discussions, and I thank the panels that volunteered to share their experiences. So we'll have discussions around funding of health IT modernization and a sample of perspectives on tribal experiences with health IT, both from the direct service tribes viewpoint and self-governance tribes. So trying to make sure we have a well-rounded conversation about this. During the last part of the day, we will focus on forging a path forward through smaller breakout sessions, and then coming together back as a larger group discussion. We will build on the perspectives which are shared today to develop a roadmap for next steps, and that we will need to take to advance health IT in Indian country in a strategic and responsible manner. So I think there's a slide for the objectives. So by the end of the summit, we will be able to identify lessons learned in previous tribal and government experiences with the health IT modernization. We will identify shared priorities and areas of concerns for health IT modernization. We'll come to a consensus, hopefully, on what we want the role and leadership of tribes to look like within the IHS Health IT Modernization Project. Remember, this project is something that is owned by Indian Health Services and is, however, they have a huge emphasis on tribal engagement throughout the process. We will create a plan, hopefully, for determining the true funding need that has been escaping us for a long time, and in order to make sure we have a true ask for what it will cost to do this, not just for Indian Health Services, but tribal self-governance tribes and those who have opted out of utilizing RPMS. So we need a plan for determining what that true funding need and also how we will resource this. We will identify information, resources, and support that are still needed. We've been talking about this for at least a decade since I've been around, and we still have a long ways to go to get to where we need to be. And then finally, we'll identify the next steps next steps for tribal leaders and tribal organizations to commit to take it to advance the Indian health modernization for Indian country. But all in all, in the end game, we all understand that really this is all about providing the best quality of care for our people. And as tribes, we know our role and our responsibility to ensure we're working together to achieve this using all of our resources, including technology and support services necessary to stay ahead of the curve rather than behind it. And we thank Indian Health Services for their partnership as we move forward. So we do realize that there are many competing events today, different, the consultation on the Rescue Act plan funding and other activities. So we encourage you to join us whenever you can. If you have to step out for a while, that would be fine, but hopefully you'll come back and provide your valuable input. The National Indian Health Board will also be welcoming written feedback, as they have in the past, on all the topics discussed today to help inform their work on this transformative issue. So if you would submit your comments or in writing via email or in the chat room, that would be great as well. So with that, we'll move on to the next presenter. It's my pleasure to welcome Elizabeth Fowler, who is the Acting Deputy Director of Indian Health Services. Liz really needs no introduction to many of us who have been around the block for a long time. She is a true partner and advocate for Indian Health Services. She is a proud member of the Comanche Nation with descendancy from the Eastern Band of Cherokee Indians, and was appointed in January 2021 to be Acting Deputy Director of the Indian Health Services by the Biden administration. Ms. Fowler began her career in the IHS in the 1990s, and I was there at that time when she started. She has also served a variety of different roles at IHS headquarters, including IHS Deputy Director for Management Operations and Deputy Director for Budget Formulation within the Division of Financial Management. She also recently served as the Executive Officer for the IHS Oklahoma City area prior to being appointed to Acting Director. And we're glad to have you back at headquarters, Liz. She has been a strong partner and advocate in advancing Indian health priorities for many years. Has been a great friend. In fact, our success can be attributed to her strong support over the years. As we work to effectively advance policies that benefit tribal nations in our communities, including health IT modernization, we really rely on that partnership to help us in our efforts. So it's an honor to have you, Liz, with us today. And please welcome our friend and federal partner, Liz Fowler.
Thank you, Carolyn, so much for that kind introduction. I really do appreciate your remarks. And good afternoon and good morning to those of you who are on the call today, on the summit today. I do appreciate and thank the NIHD for their invitation to participate by providing a few opening remarks today. Our collaboration with the National Indian Health Board and tribal organizations and urban Indian organizations is key as we make decisions to modernize our IT systems across Indian country. I do understand that this summit is a space for tribal leaders to come together and engage on issues, concerns, needs, and priorities for health IT modernization in Indian country. And we do appreciate the National Indian Health Board for holding this summit to get additional feedback and information on modernizing our health IT. Having an open dialogue is extremely important as we move forward with this vital process. I don't want to take too much time on your busy agenda today, so I just wanted to make a few comments on progress for the Indian Health Service. I'm going to start by just acknowledging how critical this conversation is today. In light, we've also noted that our consultation that is scheduled for today is also very important, and there is much to be discussed during the consultation. So we are planning to have an additional consultation session next week. So please stay tuned for additional details on the second consultation session. It will mirror today's session, so it's really a second session for those of you who would rather miss today's session and attend next week, or vice versa. Just wanted to start off by letting you know that. I also want you to know that the Indian Health Service remains committed to modernizing its health IT, and we have had some consultation on this effort throughout the project, and we plan for more tribal and other stakeholder engagement into the project as well as we move forward. The Health IT Modernization Research Project, conducted in 2018 and 2019, included in-person visits to 25 sites, and 14 of those sites were at tribal or urban facilities. Throughout the research project, we surveyed the entire federal, tribal, and urban Indian organization system and received nearly 2,000 survey results, with the majority being from non-federal sites. A final report and an executive summary from the project were made public and shared with others and, well, with the public, anyone who is interested in the project. IHS began receiving feedback on our options through listening sessions in December of 2020 and January of 2021. IHS took into consideration that all of the feedback received supported full replacement of the RPMS. Therefore, we announced that decision in April of this year to commit to a full replacement of our PMS. The benefits of implementing a new system include improvements to patient safety, patient outcomes, disease management, clinical quality measures, third-party revenue generation, agency performance reporting, and sustainable support costs. Additionally, IHS has actively solicited tribal feedback on IT modernization related requests for information 3 times during 2021. The modernization team listened and applied the feedback that we received. In a Dear Tribal Leader letter sent in August, IHS provided information on the acquisition plan that would replace our PMS. IHS also heard your feedback to support tribal health record data reporting and to include tribal, urban, and clinical users in the review process prior to making a final decision on the replacement of our PMS, the selection, in other words. We've also formed an IHS Executive Steering Committee as the initial body of the governance model. Multiple work groups will support the committee to ensure we represent a broad perspective. The governance model will allow participation by federal, tribal, and urban Indian organization collaborators who will use the electronic health record. We look forward to providing additional information when the work groups are ready to solicit participation. And while we're in the process of IT modernization, we are committed to supporting the existing infrastructure to ensure our communities and health systems have digital tools to deliver high quality care. We know how important it is to continue working together with you all, the tribal organizations and urban Indian organizations, in developing a human-centered design for health IT solutions that are rooted in empathy and equity. As we approach the proposal's release, we must take this time to ensure that tribal and urban needs are guiding every step of the project. We appreciate all of the feedback you have provided and will continue to provide. Before I close, I wanted to take a moment to thank you all for your efforts to help get our communities vaccinated. I can't not say a few words about vaccination. The recent emergence of the Omicron variant only further emphasizes the importance of vaccination, boosters, and prevention efforts needed to protect against COVID-19. Everyone ages 5 and up is now eligible for a COVID-19 vaccine, and everyone ages 16 and up is now eligible for a booster shot. I encourage you to continue sharing the importance of vaccination with your friends, family, and community members, particularly those who have not already been vaccinated. This is especially important as we gather with loved ones over the holidays and with the recent rise of COVID-19 cases across the country. Finally, in closing, I want to say again, thank you, National Indian Health Board, for holding this summit and for your continued involvement in supporting the Health IT Modernization Initiative. I also want to say thank you to our own Chief Information Officer, Mitchell Thornbrew, and Deputy Director for Intergovernmental Affairs, Ben Smith, and their team for all their hard work and coordinating input and for their work on this project. We do look forward to the discussions today and to next steps as we head into 2022. Thank you again, everyone. And I do want to just, as my final statement, say that we look forward to hearing the outcome of today's summit, and we do commit to ensuring that we will consider every recommendation that is made and to actively review and consider any tribal feedback on our IT modernization project throughout the project, throughout the remaining portion of the project. And with that, I'll turn it back to you, Chief Bell, or I'm sorry, Ms. Crowder.
Thank you, Ms. Fowler. Thank you for your positive comments and remarks. And it's very important for tribes and tribal leadership to hear of IHS's strong commitment to engaging our leadership and subject matter expert staff in this effort. We look forward to working together in partnership with you. You know, it takes tribes and the IHS working together to make this a reality for all of the Indian country, the ITU, the IHS, the tribes, and the urban programs. So we look forward to continuing to work with you. So at this time, I would like to introduce Mr. Douglas Barton. Mr. Barton is a Senior Vice President, Chief Technology Officer, and Chief Engineer for Leidos Health. Mr. Barton is responsible for the group's technology, investment strategy, oversight of independence research and development, management of solution architects, technical capture strategy, and architectural oversight of programs within the group's portfolio. Quite a title, quite a responsibility. He recently served as chief engineer for the Defense Healthcare Management System Modernization Program, which was a $4.3 billion program to replace the legacy DoD EHR. So we welcome that experience here. As they move to a commercial EHR product. We are pleased to welcome you, Mr. Barton, to provide us with some background on health IT from an industry perspective. Welcome.
Thank you very much for your kind introduction. As I was introduced, my name is Doug Barton. I'm Chief Technology Officer and Chief Engineer of Leidos Health. Over the past 15 years or so, Leidos has performed health IT modernization activities for many hundreds of commercial and federal hospital systems and clinics. And as a result of that experience, what I would like to do today is just share a few thoughts on what we have found to be critical factors for success. 3 critical factors for success, and also offer some thoughts on 3 opportunities that we believe will present themselves as you move forward with the modernization program. And these opportunities may not be immediately obvious, actually, because the market is changing so rapidly. In terms of critical success factors, the most important critical success factor by a lot, frankly, is the activity that you're engaged in today. It is communication, open and direct amongst all stakeholders as you go through the process of modernization. Sometimes that's called organizational change management, in the sense that it's planned, deliberate, and intentional. But it's essential that everyone that is affected by this change, tribal leadership, tribal members, the clinical staff, and the leadership team within the IHS, are all communicating amongst one another so that concerns can be raised and spoken to, questions can be asked, issues that arise can be discussed openly and collaboratively. The opportunities on the upside, the positive activities that are taking place, can be shared amongst all participants. And frankly, that some of the limitations and challenges that the technology will represent can also be discussed and shared. There is no perfect technology. All technology has limitations. And it's well that everyone has a common understanding and a common set of expectations as to what a modernization opportunity can provide. Because frankly, in terms of improving the health and well-being of the Indian populations, it's necessary but not sufficient. So it creates a foundation that enables other programs and activities and higher quality care to be provided. And understanding that it's a lot of change, and most people don't actively embrace change, even when it's positive change. That active communication, particularly in terms of process, status, activities, expectations, and challenges we have found over time to be absolutely essential. And while it sounds simple, just communicate, we all know that in fact, communication requires deliberation and intent and active and open participation. So the second critical success factor would be data sharing. It is highly unlikely that any individual through the course of their lifetime will have all their healthcare provided by a single physician at a single location, and that physician is documenting their care in a single health record. Frankly, in these days, almost impossible. Therefore, as you move from physician to physician, from location to location, from tribal facilities to private clinics and hospital systems, as you move around the country, your health data is scattered in many different locations. And once again, while having all that data in one place, which is sometimes referred to as a longitudinal health record, is not an end in of itself. It does create the opportunity for the individuals that provide your care to have better information to help inform the diagnosis and provision of care, and also in aggregate across a population of patients to allow the leadership that are making decisions about investment, what programs are working, what programs perhaps could be working better, to do that more effectively and in a more informed way. While data sharing is enabled by technology, and the technology, frankly, is much better than it used to be, it's important to understand that data sharing is first and foremost a business process. It is enabled by technology, and it should be viewed as a business process. And as a result, it requires a fair amount of coordination and activity between organizations that have business relationships and clinical relationships to see to it that that happens in the most effective fashion. And the third critical success factor, may go without saying, is security and privacy. I'm sure that you've seen in the media reports of ransomware attacks on hospital systems or significant breaches of healthcare data. You know, we have collaboratively and jointly an obligation to protect the data that's entrusted with us. It's challenging in today's cyber threat environment, but nonetheless, it's really our obligation. There is some data to suggest that when a patient has doubts as to whether their personal health data will be protected, they may in fact not be forthcoming with their therapist or their physician about some of their more sensitive concerns. And that is a bad outcome. So we need to be deliberate and disciplined right up front to make sure that from a handheld device, from a desktop, to a data center, to the cloud, wherever the record resides, is end-to-end protected. It's important enough that today I'm still a certified information system security professional. It's the only technical certification that I bother to maintain because I believe it's that important. And it does require continuous and deliberate attention. So in terms of the critical success factors that we found over time, first and foremost, communication, organizational change management. Second, data sharing. And third, privacy and security. When those things are being addressed and you start to move forward, I'd like to briefly suggest there are opportunities that will become available to you that may not be immediately obvious from the outset. Clearly, being able to have a longitudinal record, provide better care, have a better patient and physician experience are all opportunities and upsides. However, if you watch the market and where people are investing, there's a tremendous amount of investment in what people are calling alternate venues of care. And you can think of that as any care that takes place outside of the four walls of a hospital or a clinic. It can be in your home using telehealth or remote patient monitoring. It could be at a community center. It could be monitoring you while you travel. It could be monitoring you at work. That, generally speaking, provides more immediate feedback. And frankly, sometimes it's difficult to travel to a hospital system or clinic. And being able to receive adequate care at home, even sometimes acute care, because there is an emerging concept called hospital at home, is a much better patient experience and frankly can provide great care to individuals. Having that integrated with the record that's managed inside the four walls of a hospital or a clinic is an essential element of that. And modern healthcare technology permits that. The second, perhaps not very obvious opportunity is integrating consideration of what is called social determinants of health into the care plan. It's hard to be healthy if you don't have adequate nutrition. Sometimes you can't travel to a doctor, and how is that going to be addressed? There's a great study that showed how there was a patient that had COPD, which is a lung disease, constantly readmitting to the hospital. They sent a nurse home with this individual, and they looked at the couch this individual was sitting on. It was filled with mold. So for a few $100s, the nurse got a new couch, took the old one away, and the patient stopped readmitting. It was healthy. Now, is replacing a moldy couch healthcare? That's an interesting question. It certainly stopped that individual from readmitting to the emergency room. So there are a broader set of concerns that have real impact on the health and well-being and frankly happiness of individuals that intersect with the healthcare system that can now be considered in an integrated way with modern records that are able to track and integrate this data. And the last opportunity is what I would call health and wellness. Most of what we call healthcare is actually sick care. We go to the doctor when we don't feel well. We don't go to the doctor when we're feeling great, generally speaking. But what people want is not more healthcare. They want more health. And helping people have healthy habits and have activities that promote their health and well-being that they can control as individuals, but making sure that that information doesn't stand alone, is integrated into the broader health record and the healthcare plan, is an emerging capability that's frankly advancing at a furious rate in ways that we believe are going to change the way people view how they manage their personal health and frankly affect healthcare more broadly. So that's a third opportunity. And there are obviously other things like revenue cycle management, recover more from billing third-party insurance and other things. I would take those as foundational, but understand that the market is rapidly evolving and a modern technology platform will let you take advantage of some of these other activities as they come along. With that, I'll simply thank you for the opportunity to speak with you today. I wish you well in this activity, really a once-in-a-generation opportunity to dramatically transform your health information technology. And I thank you for your kind attention.
Thank you, Mr. Barton. Again, we appreciate your coming and sharing these very wise thoughts with us. During the Health IT Modernization project that we went through in a year and a half ago, 2 years ago, we found it really beneficial to reach out to industry to get perspective and to share experiences. So we value your time today and your contribution. And also, again, for your generous support of today's summit. We really appreciate that. So I think we're going to, at this time, move on to the next session in Health IT Modernization. And I have the pleasure of helping to present today with AC Locklear, who is the Policy Analyst for National Indian Health Board. Thank you, AC. And we will talk a little bit about Health IT in Indian country, kind of where we began and how we're moving forward where we are today. So go ahead and start the slides. So I want to take you back to the Tribal Self-Government Governance Amendments of 2000 that established Title V, and talk about a little bit about the tribal shares for the Office of Information Technology. I happen to be the co-chair for the National Tribal Shares Work Group at the time, and the pioneering tribes that participated in self-governance participated with the Indian Health Services and looking at all the functions of the headquarters and area offices to determine which of those would be considered tribal shareable, meaning that tribes can opt to take shares of the funding or keep funding with the Indian Health Services. So when we looked at the Office of Information Technology, there was a huge discussion that took place at the national level about whether or not the Office of Information Technology and its management of RPMS could be determined as an inherent federal function, meaning that this is something that the tribes would not have access to in terms of tribal shares. And after long deliberation, it was determined that the Office of Information Technology and the RPMS, management of RPMS system was not an inherent federal function, and in fact could be taken, shares could be taken by tribes, but also, you know, the whole function could be assumed by tribes in the future. So all OIT program services function activities were eligible for tribal shares and funding agreements, or based on the law portions thereof. So people could take their headquarters shares, they could take their area shares, or they could take all of them or portions of them. So at that time, OIT had, you know, their major role was managing the RPMS legacy system, which was developed over in the 60s and launched as officially in 1984. It's important to note at this time that OIT did not have its own appropriations budget line, that their source of funding, even into the 90s and early 2000s, really were buried within direct services and hospitals and clinic line items. And in fact, when I was chair of the ISAC committee, it often was a challenge for OIT to find the resources necessary to do the development and investment in RPMS, having to sweep funding where they were able from other unspent line items to do so. So funding for the OIT has historically been below private sector industry standards and has pretty much remained flat, except for recent years where the Health IT Modernization kicked in. So let's see. So many tribes opted to take their small amounts of tribal shares. They had been increasingly frustrated with RPMS as a system over the years because of this lack of investment in RPMS, and it kind of came to a head at one point when you know, tribes were requesting that third-party revenue, and the ability to capture revenue for tribes needed to be a priority, and it just kind of had a slow start within Indian Health Services, and many tribes were frustrated with that. And then as there were increasing demands and needs that tribes had from their electronic health systems, they became frustrated and opted to take their small amount. I say small amount because I remember I mentioned that the budget was pretty minimal for OIT, opting to take their small amount of tribal shares to invest in commercial off-the-shelves or COTS systems, and then supplementing those, of course, necessarily with tribal funds to be able to make that work. So the tribes and tribal health organization options for taking OIT shares: you could retain your share, PFSA shares, with the Indian Health Services, the PFSA function, and the shares with either headquarters or area office, or both. You could withhold your OIT shares, and then there was an option then to buy back OIT shares if you wanted to. I think it's really important for the audience to note that within the self-governance rules and regulations, tribes may at any time retrocede the PFSAs and accompanying funding back to IHS in exchange for services. So while it may not have been attractive back then to keep your shares, your small amount of shares in with headquarters and area offices, there may be incentives should we, in this modernization era, develop a robust system. There may be an interest in tribes to relook, and there has been some tribes have mentioned that they'd be interested in looking at that and possibly giving back their shares to be able to take advantage of the system that IHS is developing. So where we are now, tribes' call to action. Over the past decade or so, there's been a push for modernization of the ITU health system. And there has been a very loud request from self-governance tribes who made the decision to go with their commercial off-the-shelf systems to advocate for fair and equal funding to reimburse for their tribal investments in their COT systems through the budget formulation process. So if you look back at testimony for budget formulation, this issue has come up repeatedly over the years and has been voiced actually to the past and current IHS directors. So HHS initiated a health IT modernization research project. As Liz had mentioned earlier, this really was to jumpstart actually taking some action at a high level to look at RPMS, especially in light of the VA's decision to move to a COT system at Cerner. And this process and this research project engaged tribes in all 12 areas, as Liz mentioned earlier, through listening sessions, data calls, and focus meetings with stakeholder groups. The final report was published in November 2019, which provided 4 options to modernize the health IT. And that report is what actually assisted then Indian Health Services in being able to move forward with their modernization effort. So then in April of 2001, IHS did make the decision looking at the 4 options to select option 4, which was full replacement of RPMS through implementation of centralized modern core health IT system. And within that, based on the feedback they received from tribes and direct service tribes and self-governance tribes and urban Indian programs, it was really important that this replacement not just be of the system itself, but also include infrastructure. As you know, we're doing some tremendous build out of broadband and infrastructure in communities now as a result of the CARES Act and the rescue plan, as well as support services. So those 2 components were really important. Support services include training and then workforce development. So the cost of IHS, for the IHS portion, as Mitch has reported in various meetings, is estimated to be $3 billion over several years. 8 to 10 years, and this number has remained constant as we work on budget formulation and estimate what that cost will be. So you'll hear that number $3 billion over several years, although we'll have some discussion later about what the tribal need would be for this same effort. So self-governance tribes continue to advocate for fair and equal funding to reimburse for tribal investments in commercial systems and for infrastructure and support services, both through the ISAC, which is advisory to the IHS director, and through the budget formulation process. We just finished our area meetings and going into a national meeting next year. And this has been a priority. Health IT modernization has been a priority for budget priority for tribes for the past few years. So I'll turn it over now to AC, who will carry forward with the rest of the session.
Thank you, Carolyn. So for the next portion, this is just a timeline that highlights a few of the items that Carolyn mentioned, starting with the HHS IT Modernization Research Report in November 2019. It also highlights the steps that IHS went to before the decision for the full replacement of RPMS, along with the most recent events, which include congressional data calls, additional listening sessions, virtual industry day, so where we are now. Right now, in this past summer, IHS released a draft statement of objectives to seek comments that they will include within their RFP. And that was, comments were due at that time, and now those will be included in the request for proposals that is supposed to be released sometime before the end of this year. Next slide. So we've included a couple of slides that were provided in the most recent IHS OIT report, specifically around some of the key topics that we're going to be discussing today. This first one is around travel participation in governance and system design. Essentially, one of the items that we really want to highlight today is how travel leaders, how tribes can be engaged in this process going forward and where they would like to see themselves represented. This is part of the IHS OIT's plan for tribal participation in governance over broadly, including work groups responsible for recommending standards that would shape IT modernization, representatives to really understand local business processes that incorporate that into the system, and other different methods to solicit input for developing recommendations for how the implementation will go. So, please. As Carolyn kind of mentioned, there have been, next slide. Oh, there we go. As Carolyn kind of mentioned, some of the funding pieces, but this slide really demonstrates the funding that has been allocated for HIT modernization, starting in fiscal year 2020 and appropriation to the project management office. This is really to start building out OIT's function in the project whole process. The CARES Act of 2020 provided 6.5. The CARES Act of 2020 provided $65 million one time to accelerate the project. 2021 appropriations increased from that original $8 million amount to $34.5 million recurring for the project. ARP in 2021 provided $70 million of one time for the IHS electronic health records. And in addition to the project specifically, there was $141 million from the CARES Act and American Rescue Plan Act distributed to ITUs, facilities, and sites for telehealth and technology and other infrastructure needs. Next slide. This slide demonstrates IHS OIT's contracting strategy. So as we mentioned, out of the 4 options that were originally proposed in the HHS project strategy, complete replacement was chosen. So contracting strategy is really to replace the existing RPMS infrastructure platform with the enterprise HIT solution. And the plan request for proposal releases in first quarter of FY 2022. And next slide, please. This is the national schedule moving forward as of December 2021, with expected release of late this year, with the award being given summer 2022. Systems build, configuration, and infrastructure work, initial site selections 12 to 18 months following, initial go lives late 2023. And obviously all this is dependent on funding, experience, and different elements within the acquisition process. Next slide, please. So earlier this fall, NIHB, when we were deciding to whether or not to have this form, we really wanted to get a pulse on how Indian Country felt about the current health IT modernization process. We really wanted to see really what Indian Country felt, whether they were satisfied with the various elements, whether their priorities were represented within the project itself. And this is just some of the findings that we had from that initial pulse survey. Next slide. First, the respondents expressed low confidence in the IHS IT modernization system, with less than 17% agreeing that the health IT needs of tribes and urban health facilities are sufficiently met. There was very low agreement and low confidence with the priorities of tribal leaders, as well as the priorities of the health facility staff. Next slide. This slide shows that few respondents were satisfied with the frequency of opportunities for tribes to provide input, the methods that IHS has used to solicit said input, and with how the project is going overall. Next slide. And these are some of the priorities that were really concerning for this from the survey. The first priority that identified as a top priority was modernizing IT infrastructure. So they were concerned about the project's focus on adequate bandwidth, network communication software, hardware, and support. The second was tribal representation in project governance and leadership. The third was seamless data sharing and interoperability between facilities and external databases. And the fourth was electronic health record interface, ensuring that it's easy to learn and navigate, and it's designed to support all areas of care. Next slide. And these are just some additional things that were pulled out from the survey that are just kind of food for thought. There was a low confidence in understanding the details of the project, that there was a need to incorporate the unique needs of tribes and see that represented and communicated better. The pace of the process was very slow and it needed to happen faster, and that significant training was needed. There were comments about setting up an EHR tribal collaboratives for tribal using, and there was discussion about workforce shortages of data scientists and analysts. So with all of those, when we were designing this summit, we really felt that these were our three calls to actions that really going to highlight everything we're going to do today. The first being, what does tribal engagement in the current IHS HIT modernization effort look like? So we want to really hear about what and how tribal engagement should look. What strategic action do tribes need to take to achieve full funding for ITU HIT modernization for all? So what can tribal organizations do to find out what that number is and how to achieve full funding? And what should the future for ITU HIT modernization system look like? What are those elements? What is that governance structure? What is that funding look like? So what should the future of this look like? And I will turn it back over to Carolyn to close us out.
Thank you, AC. I really appreciate that feedback and sharing of the current concerns through the pulse survey that National Indian Health Board has taken.